Well, thank you very much, and I'm very grateful for the organisers for the invitation. And yes, slightly wary, I guess. You know, an orthopaedic surgeon you've invited to set the scene for a finance conference about pricing. That's brave of you, but you're known to be a brave nation, so I will try and step up to that mark. The title I've put up there is perhaps a little provocative. Do you really want the clinicians to run healthcare? I hope over the next 45 minutes or so, I'm going to give you some reasons why you need certainly to be working much closer with clinicians, particularly as we all tighten our belts. And you won't appreciate perhaps quite how tight the belt has been drawn in England and the UK over the last few years. And I'll give you some flavour of that. But in essence, what I want to cover today is around how we have taken the concept of pricing and contracting within the NHS, how we've used an activity-based funding model and built into that quality and outcome metrics, which have driven changes in the NHS nationally without an increase in cost, which has been really very rewarding, particularly for our patients and our clinical teams. I'll also just move on to explain a little at the end about where we perhaps have reached the limit with activity-based funding and what we're now looking at, particularly in unscheduled care. So my responsibility, as Tony said, was initially as being brought into the Department of Health, into the government, and we had this system initiated really under Prime Minister Tony Blair, where when they had a difficult government policy issue to sort out, rather than doing it with mandarins and bureaucrats behind desks in Whitehall and in Westminster, they pulled a lead clinician out of the NHS and said, "You sort it out for us." Now, I was one of those. We were given the title, as Tony said, a czar, but if you know the history of the czars, that's perhaps not a title you want to be given. Subsequently, the NHS has changed significantly in England, which I'll mention, and I now work, I'm seconded still, I'm still a surgeon, but I'm seconded from my university to work for NHS England, which is an arm's length body. So let me just frame it a little bit, because this is important context for you to understand how some of this may be relevant to where you are in Australia. Some of it won't be, but I hope some of the concepts and perhaps some of the methods will be. So the 2012 World Bank figures suggested we had a very similar proportional spend of GDP on health. Since then, in England, and we now are 4 separate countries in the UK, in England for health, we have pulled out enormous amounts of money, and we're now down to below 9% of GDP. So in equivalence, in terms of US dollars as a common currency, in the UK we're spending about 3,500 per capita per year. You're spending about 5.8, and always for comparison to make us all feel good, the US comes in at 9.1. The UK and England is almost totally a public system. The private spend is because the general practitioners are technically private, and a very small amount of work is done, usually scheduled care in the private sector, but it's nothing like the system you have here. And it works as one national system. There's no segregation in terms of the geography, apart from the fact the 4 countries are separate, and I'm only talking about England. Now, we've had activity-based funding and a payment-by-result system for scheduled care since about 2003, and then gradually introduced to unscheduled care, outpatients, and A&E activity. So we've got more than 10 years' experience in this part of the world. In 2012, we went through the most fundamental change in the NHS since it was created just after the Second World War. And essentially now, the government, with the Health and Social Care Act of 2012, has handed the NHS over to arm's length bodies which are independent of the politicians. They're called arm's length bodies. I can tell you, since I meet the Secretary of State very frequently, it feels more like finger length, but they are arm's length bodies in terms of their statute. The government remains accountable for setting the policy, deciding on the funding, and once a year sets a mandate for each of the arm's length bodies, and we have them for public health and for health education, sets a mandate which tells those bodies what the government policy is. It doesn't tell them how to deliver it, just what it wants delivered. Each of the arm's length bodies in NHS England is then responsible for the how. NHS England commissions all the specialised services. It commissions primary care and general practice, and it assures the satisfactory commissioning of all the rest, which is about 68% of the spend, of what are called clinical commissioning groups. Now, these are statutory independent bodies that exist locally across England. They are membership organisations of general practice, and they are given about £68 billion worth of spending that they are solely responsible for. We cannot tell them how to spend it. We can pass on the mandate. We can assure that they are capable of commissioning, but it's up to them to design how they spend that money. And that means the vast majority of local hospital services, all the community services, the ambulance services, the emergency phone lines, all that sits with 209 completely separate independent statutory bodies. Overlying that, in the system now, we have regulators, we have Monitor, which is a bit like this organisation, but it has very strong statutory responsibilities and can step in, and does after inspection, and put hospitals into special measures. They can sack the board, they can put in a new board, and they can essentially take them out. We also have the Care Quality Commission, which is the care regulator, which is separate, who have the same powers, who, if they find standards of care are poor, and every care home, every general practice, every social care provider, every hospital is inspected by both of these organisations and can have the powers to step in. So we're in quite a different landscape now in England. As I go on in this talk, I'm going to make these three assumptions. And it's the last one that I'm going to predominantly focus on. Because for all the work that we all do at the national level or state level, actually, the decision about how money is spent, what is spent and how much is spent, the vast majority of occurs at the patient-doctor or patient-clinician interface. And if we aren't influencing that, then a lot of what we do can just be pie in the sky. And I'll come back to that and explain how we've moved that forward in England, which I think is the lesson that I'm here to share with you. You have a very similar age health cost curve, I'm sure. We've got an ageing population, increasing comorbidities. Over the age of 70 in England, more patients have more than 4 comorbidities than less. So we have a seriously demanding elderly population. And the funding issues that we've had since the recession have been far greater than you've experienced. We are now heading into our 5th year of essentially no growth. That means we've had to pull 3 or 4% out of the health service each year for the last 4 years. That is an enormous amount of money. And the system still stands up, the system still delivers, and probably is delivering very little different from how it was at the start. But we have a predicted gap now of 30 billion. And we've just had an election, as you may be aware. The Conservative Party make up the new government, and they have come into power on the commitment to maintain the austerity and maintain the significant financial improvement that's been seen nationally compared to most of the rest of Europe. So that is what the electorate have asked this government to do. So we can anticipate this slide is now out of date. And whereas we were predicting from 2015 onwards, we'd have a 2.4% increase in spending power in health, we probably will not. So we have been experiencing enormous limitations on funding. And that's a really important context. So within the NHS, we have now a 5-year forward view about what we've got to do. We are anticipating taking out essentially another £22 billion, so 44 billion Australian dollars worth of savings before 2020. And the government has committed to put in 8 billion more in terms of money. And that will really hold us at a steady state. And in that context then, how on earth are we going to innovate and bring in change? Well, one of the things we've learned, I think, over the last 5 years, sometimes it's much easier to make the bigger transformations in care shifts when there is no money on the table, because nobody can ask for it. Everybody's got to solve the problem. You can't say, I'll do it, but it'll cost you. That's not in the equation. It's either you bust or we don't do it, or one of those scenarios. And if you think we're going to achieve this sort of saving or have achieved this sort of saving across the NHS in England by some magic top-down system, then you've got a ministry that we don't have in England and it only exists in Hogwarts. Because it isn't going to happen that way. And I'll go back to the point I said that the vast majority of spend occurs at the patient-clinical interface, and if we haven't got that sorted, then most of what we do will not deliver. So if it's about quality and cost, then we have to understand what we mean by quality. And again, in NHS England, we have a very clear quality definition of framework. And we spend a lot of time on this, and it does very much set the scene for how we go about designing our commissioning, our contracting, and as you'll see, our pricing. So quality is a combination of the three things. You've got to have clinical effectiveness, you've got to satisfy patient safety, and it's got to be a good experience for the patient. And the first thing we have to do is to clarify what we mean by quality, whether it's for cohort, whether it's for population, whether it's for a disease group. We also have to agree how we're going to measure quality if we are going to manage and commission and assure against delivery. It's also important that that quality is published and it's transparent. And if we're going to drive quality, then there have to be rewards in the system that make people move on from where they are. That requires a lot of leadership. It doesn't require people to commentate and moan. It requires them to be engaged and leading. And once you've got that, you can engender the sort of innovation in the zero funding model that we've had to do. And once you've got it in place, you've got to safeguard it. And that's what we mean by quality. And that's the process we walk through each time we try to make a substantial shift. And what I'm going to try to do over the next period is to suggest to you that I can offer you some compelling evidence that it is possible to change professional behaviour, i.e. change the spend at the patient-clinician interface to both improve quality of care and reduce cost, which is what we all need, which is value. You can decide whether I've convinced you at the end. We have a long history in England, in the NHS, of trying to drive top-down quality improvement by financial incentives. And you've actually had a recent commission reported on safety and quality of health in healthcare in 2013, which I think is a very good summary document. But that concluded there was little evidence of impact. We've tried best practice pricing initiatives, for which we have got some good evidence, and I'll come back to that. We've tried commissioning against quality standards. We have a quality premium, which is a top slice 2.5% payment we take off commissioners if they don't commission and deliver on it. We have a quality outcome framework we apply to general practice to make them do a lot of preventative medicine. And we have something called a sequin, which is an improvement model which we put in nationally and locally that tries to set up innovation and change. None of those three have really shown good evidence that they change things. And we've also tried preferential pricing, So give a better price with a better profit margin, as it were, to day case surgery over the same procedure done as an inpatient. Again, limited success. And there's still a lot of unknowns that despite us trying all these things over the last 5 or 8 years, we still don't know, should it be patient-based or institution-based? Is it an incentive or is it a sanction or is it a mixture? And what sort of proportion of an activity-based funding payment should you use? Because you want something that's going to improve as an incentive, but actually you can't afford to risk instability in provider organisations, particularly in England, that are right on the edge financially. We also start to be aware that there might be some case mix shift to the lower risk patients, where they're more likely to come in balance. And a real issue for clinicians is the collateral damage that occurs if you set a pathway improvement in one group of patients and watch it occur at the expense of another group. And we've had to play with all of those factors going forward, and you'll see those come out as I go further into what we've been doing. So perhaps there is a ministry of magic, or at least somebody who does miracles. Because we're so good, clinicians, writing guidance, quality standards, us designing pricing structures and costing structures that should do it, but actually, what makes it land? How many of you did biology as a school subject? Hands up. Good. Let's do your first dementia test of the day. Remember what an amoeba is? That unicellular organism that's been around for billions of years, that will be around billions of years after mankind has disappeared. That unicellular organism with a nucleus and a chunk of protoplasm coming back. Can you still draw it, remember? Yeah? I hope so. So why do I say the NHS is an amoeba? Desmond Morris? Remember who Desmond Morris was? Wrote The Naked Ape, wrote Man Watching. He was a zoologist and ethologist who watched human behaviour and described in Man Watching how we interacted and what all our expressions and body language meant. Well, I'm a bit like Desmond Morris. He said, I haven't been man watching. I've been NHS watching for 30 years. And the NHS, like your healthcare system, is made up of people treating people. And therefore, it behaves like an organism. It doesn't follow business rules. It doesn't follow financial rules. It doesn't behave like a company or an institution. It behaves like an organism. You can push and pull the protoplasm as much as you like of an amoeba, and it will reform back into the shape that it feels most comfortable with. Does that feel like the health service? And if you stress an amoeba, for those who did advanced level studies at school, you remember that if you stress an amoeba, it forms a cyst and won't go anywhere. Does that feel like healthcare? So if we want healthcare, we want that amoeba to move, what we've got to do is to create in front of it a nutrient environment such that all the components of the protoplasm want to move towards that nutrient environment. Whether you're the clinician, whether you're the local management director, whether you're the finance director, whoever you are, you want to move towards that nutrient environment. And if you want to speed it up, you can have a slightly noxious environment behind it. That's called a sanction. But if you think about healthcare and moving healthcare systems in that way, you'll have a much better understanding and you are much closer to that patient-clinical interface and what's likely to shift it. Okay, so how do we do it? So the first thing is to bring clarity to quality. What do we mean? That means we have to identify the key interventions in the patient's care pathway that will really improve outcome. And how do we do that? What we do is we bring together a multi-professional group of all the clinicians involved in the pathway, from general practice through to rehabilitation, whatever the pathway is, and we bring in patients. We feed them with all a review of the current evidence and guidelines that are out there. We feed them with as much information as we can from the activity data that we have, from our registries and from our hospital episode statistics. And let them come to the conclusions about what are those important things, either for which there is evidence or there is strong consensus that it's the right thing to do. And behind the scenes, you and I are working, looking at the clinical standards, looking at the health economics behind this, looking at the operational delivery in the workforce, about the practicalities of what that group's discussing, and feed that back in so what they come up with is not something that's completely pie in the sky, but is based in reality. And at the end of the day, we want a set of recommendations that come from them that are measurable, commissionable, and can be aligned to a payment system. And that's the process we go through. And we build that in public. We don't do it behind closed doors. So the documents we're producing are out there as development drafts over and over again. So there's many people who can comment as wish to. And while you've got those people in the same room, and they've just sat down and agreed what all those things are that are really going to be the key interventions that will change the outcome for the patient group, before you let them out of the room, you say, right, and as patients and clinicians, how do you think it is fair to judge your system? By what do you want your system to be judged? So that when we come back to performance manage you against this, you don't turn around and say, well, that doesn't make any sense. Because one of the problems we face is that many of the metrics we try to manage the system on are alien to clinicians, and they are alien to real quality. So we talk about readmissions as if readmissions are something that's really bad. No, it's not. If you go into a really progressive system like we're trying to move to in England now, where we're doing a lot of discharge to assess, moving patients out into the community much earlier, their assessments in the community, we bring the care in, we know that more of those patients are actually going to have unforeseen complications and problems that would have arisen in hospital in the old system. Now they're going to arrive, and we want a really dynamic system that brings them back into the hospital. So the readmission rate will go up, not down, but that's a good thing. And is length of stay some indicator of good care? So is a short length of stay indicative of really good, efficient care? Or is it precipitous, unsafe discharges? Is a long length of stay caring, good setup, good planning, good discharge planning? Or is it just total incompetence? So a lot of the metrics that we have access to that were designed for activity and payment systems are not relevant when we're trying to talk about quality and transforming services. So again, we've had to move beyond that. So in England, we have now a lot of national clinical audits. They're funded by government, but independent of government and of the commissioning bodies. We have 53 at the moment, and we are setting up another 4 or 5 every year across the breadth of healthcare. The one I'm going to give you an example on is the Hip Fracture Registry. Because it was the first one that we really pushed forward on, and we're now into our 5th year on this one in terms of using it as a commissioning tool. So we sat down the patient group, we sat down the carers, we sat down the clinicians from the physiotherapist to the GP to the surgeon to the anaesthetist to the geriatrician, and we asked them, based on the evidence and on the data, what were the things that would really change the outcome for the patients, for them, for their mothers. And these were the lists they came up with. There was something about the time to surgery, that there shouldn't be a delay. There was something about being admitted under the joint care of a geriatrician, as well as an orthopaedic surgeon. The average age of a patient now with a hip fracture in England is 85, and the average patient has more than 4 comorbidities. There was something about agreeing all the assessments that were going to happen, because all of these patients are unfit for anaesthesia, but they've got to be anaesthetised, they've got to have this operation. So let's agree how we're going to set them up. Let's agree when the geriatrician's going to be involved. Let's agree that they all get their bone health checks and their falls assessment before discharge. And this is a group that has 40% dementia, so let's make sure we've got dementia assessments built in there. And that's what they came up with. And then we said, well, okay, so if we're going to put some quality payment behind this, to innovate and to push on that best practice. Should we give 50% of the money for half of them or whatever? And the patients were quite clear. The patients said, well, if this is my mother, she should get best practice. I don't want half of it. So from the patient's point of view, there's no question. It was all or none. So it was either my mother got all of those, or you didn't get the money. We already have the registries. They already publish data by hospital each year. And that's a public document. It's on the websites. And every one of those lines represents one of the 250 hospitals in England. And you can see exactly how they're performing. And the variation is as you'd expect across healthcare. So how do you then financially incentivize those criteria for that patient group? So it's really important that we get the money moving in the right direction to incentivize the right behaviours. And when we know we've done it right, it's when the finance director meets the orthopaedic clinical director in the corridor in the hospital, and they both want the same thing. So this is how we develop tariff. It's a standard model. So each hospital returns its reference cost for the HRG. You have DRGs. We then come up with an average national price for what that costs last year in the health service. That's paid per patient at a spell level. We put in a cost improvement or subtract a cost improvement from that figure going forward, usually about 3%. That's published, and that becomes the new price for next year. That's how we come up with the ordinary tariff. What I then did was I persuaded the Treasury to lend me some money. I took the original base tariff. I set up an additional payment to be added to the tariff, and that was based on what the average hospital of an average size would need to do in terms of investment to be able to meet the criteria. That was usually around more operating time and more geriatricians. We then looked at that and looked at the compliance that already was in the system for those criteria to be met. And our experience is that if you've got about a 25% compliance in the system already, you've probably made the judgment at about the right level, and you can anticipate getting up to 75 or 85% compliance with your tool. If your compliance is too low, it's too hard to move the system. If it's too high, the system won't bother. So that's how we set it up. So there are two parts to the tariff. There's the core tariff, which was reduced for the compliance. We started off at about 9% was how that calculated. What we found in the first year was those places that were keen and set up, and both the finance team and the clinical team in the hospital wanted to move, got on and did it. Those where there was a tardy clinical group or a tardy finance group struggled, so we doubled it the next year. And then we've now settled at something like 20% of tariff is based on those 6 criteria. So if Mrs. Miggins gets best practice, you get 20% more money. And that's worth quite a lot. That's worth quite a lot of money for any individual hospital. So that's how we set up the best practice tariff payment. And the way that is managed, we have a very nice safe triangle, and I would recommend this if you're thinking about it. So the local hospital clinical team return data on each individual patient to the National Hip Fracture Registry. The registry is run by clinicians. The return data is by clinicians. Any arguing over the clinical data is between clinician to clinician. The registry then reviews those data and lets the commissioner or the payer, whoever, know whether or not Mrs. Miggins did or did not receive compliant care. The commissioner checks that it's her, that patient is theirs, and then makes a quarterly adjustment to the hospital as an additional payment of that 20%. For your average hospital in England, which has about 300 and 350,000 population served, that's worth between $1 million and $2 million Australian dollars of lost or gained income. That's enough to get most finance directors out of bed. And it's certainly enough to mean when clinicians knock on finance directors' doors and say, look, if only you let us have a bit more of this, that, or the other, we can deliver this, you'll be financially better off. And by the way, we know this is right for patients and carers. And if you remember nothing else about what I say today, just remember this slide. This is 16 successive quarters for each of those metrics. So getting to theatre within 36 hours, having joint care with a geriatrician, being admitted under a joint protocol agreed by orthopaedics, geriatrician and anaesthetist, being assessed by a multidisciplinary team, having a falls assessment, having a bone health assessment, having the mental test score and dementia screening done. As we increased the financial element, as we listened, we have seen 16 successive quarters of improvement. I'm waiting for the current year's data to come out, but in essence, everything has got better. And because we did this on pricing and we knew that it was effective, the cost has been neutral. Now, that is a national experiment on over 250,000 of the population. That's an enormous shift. And when you talk to clinicians, you talk to the nurses, talk to the therapists around the health service, they see this as one of the most important things that they have seen change in their clinical careers. The old people are not waiting days, being left at the end of operating lists, not being given priority, ending up with very poor outcomes. Nationally, and this was not expected, we've seen a 15% reduction in the 30-day mortality. And this is a patient group that's 85 years of age. And that mortality reduction is still there beyond a year, which means that we were really doing harm before, and part of what we've done is to reverse harm. Independent valuation, scrutiny, Nuffield Trust and Health Foundation have both reviewed this and shown that mortality reduction is real. And it's been independently scrutinised by the Audit Commission that's looked at best practice tariff and concluded that it is effective in driving change because you have a strong clinical drive attached to a strong financial incentive, and that combination affects what decisions are made at the patient-clinician interface. We have commissioned a full review now because I wanted 4 years' data before we really started to make sure this wasn't some observation effect. We commissioned a review after the first couple of years, and we actually showed that we were spending no more money. And what everyone had always said was that if we treated old people with hip fractures well, it would be cheaper than treating them badly, which is what we thought we were doing. And that seems to have been borne out by spend. So then I took on major trauma as the next challenge. And major trauma had been unresolved in England for decades. We plagiarise Victoria State trauma system because I think it's a fantastic system, and I have even written to ministers here to indicate that. So we copied very much what you'd done here in Victoria as a trauma system. We set about doing the same thing. We had a clinical and patient group. They came up with the preferred model of care and the preferred model of rehabilitation, which I won't go into, but that's what they decided was the right thing that should happen. We then set up 22 regional trauma networks across England with 27 major trauma centres. That serves a population of 53 million. We built that around the Trauma Audit Research Network, which is the Trauma Registry in England. I brought it under national commissioning so that we could drive the quality improvement. We set best practice criteria which drove patients into the major trauma centres, which gave them consultant input, which made sure all the specialties responded and took them seriously. And that was very similar to the hip fracture work. We set up the same safe triangle. Disputes between the registry and clinicians occurred at one place. Any argument between finance and the funders occurred in another place. Compliance was checked. An additional best practice tariff was made to each of the major trauma centres based on the care the patient received on those criteria. And when I set it up, clearly the big university hospitals wanted to become the major trauma centres, so I knew they wanted some skin in this. So I didn't give them all the money they needed, because that was a good way of getting them to really change their approach. But what I did do was make sure that the major trauma centres were only going to be financially viable to provide those services if they delivered best practice care. If they just took the name and didn't deliver, then they would not have got the income. We saw the same thing in terms of improvement in criteria being met. So we saw transfers improving, we saw consultant presence improving, big experiment again. These are the data for the first 2 years, and this is about the patient being met by a consultant as they come through the door. Before we did the change, about 4,000 patients in England with major trauma were getting about 50% consultant hit rate in the major trauma centres. After the change, 3 times as many patients were now being taken to the major trauma centres and not going to local hospitals, and we're up at over 70% of consultant receiving the patient at the door. Sorry. One of the big problems we all have with healthcare is how do we get research into healthcare? We know it takes over 15 years very often for level 1 evidence to really permeate into healthcare. There's a drug called tranexamic acid, which is cheap as chips. It's cheap as an aspirin. It's been used for menstrual pain for decades. Costs nothing. Big study, Lancet, showed a significant international reduction in mortality from major hemorrhage and trauma. In England, 2 years after the Lancet paper was published, the take-up rate was about 5%, typical of across the world. We built it into best practice tariff. That's what happens. Suddenly, patients get it. Everybody knew it was right, just people had to change behaviour. It wasn't rocket science. And this is the second slide you can remember. And these data are not yet public, but you're seeing them. They may just be slightly confirmed. But this is what has happened to the odds of survival of a patient who has suffered major trauma. So we've seen something like a 50% increase in your odds of survival since we introduced major trauma networks and major trauma. Now that is absolutely fundamental to what we're all trying to do. It's about saving lives, doing the right care for patients, and this is so easy to get clinical buy-in because they designed the buy-in. These figures mirror those that Victoria State Trauma System managed to do in the 10 years ago now. So I'm, again, really grateful for the advice and lead. But again, this is on a much bigger scale. This is on a national experiment of 50-odd million people, 65,000 patients in this study. And when we look at the patients that survive now that didn't before, it's across the board. It's not just those with the very serious injuries. Those with a probability of more than 95% chance of surviving, more of them survived. Right across the board, we've seen an increase in the chances of survival. That equates to about 700 lives a year. This sort of stuff is really powerful in clinical arenas. And for those of you who like your figures, who like your statistics, and for me as an academic, then this is the funnel plot of where what the hospitals that were university teaching hospitals sat in terms of their performance for trauma prior to the major trauma networks being introduced. Just hold that in your mind and look at the distribution in the funnel plot. This is what happened afterwards. So not only have we shifted the baseline, we've reduced the variation. And that's something that I think is one of the most difficult things to achieve in healthcare. It's very easy to innovate and run forward with those people who are leading edge in the technology and desperate to do it. It's so difficult to bring up the rear, and we often end up widening variation when we innovate. Again, it's a big national experiment, 21,000 patients in there. So it's again, how do we keep this going, and how do we report, and how do we assure it? So these are public data. So every single hospital, the data of its performance and rate of survival is published on a national website. They can see exactly where they are compared to the rest of the country. And there's really simple explanations for the public to understand what that means and whether or not it's significant or not. From a commissioner level, we get a dashboard like this, which shows the trend of each individual hospital against the national improvement trend and against the 10th and 90th deciles. The next step we've taken, because that's very much around process, it does end up with outcome. And what we are doing over time is each year we look at the criteria, and when we get a criteria that's being met quite comprehensively, we tend to drop it and bring in another one that stretches the system a bit more. And we move one away from a process measure. And I don't apologise for using process measures. When you want trying to change process measures are really useful. Once you get past the process change, you then want to move into outcomes and lose the process measures. The other thing we want to bring in is patient experience and patient outcomes. So patients reported experience and outcomes from the care they've received. And this is another initiative now which we're pushing out across some of these areas. We're looking at it in major trauma at the moment, and we've already looked at it and implemented as part of the payment system for hip replacement, knee replacement, hernia, and varicose vein surgery. So for each of those, in a consensus way like before, we have agreed a condition-specific score, patient-reported score about their outcomes, and we've put a generic score in EQ5D, which many of you will be familiar with as a quality of life measure. So those two scores come together, and the best practice tariff, if you like, is described by those reported by patients. In England now, we've also moved on to report not just publicly at the hospital level, but each surgeon's performance is reported. And this is again with support of the Royal Colleges, so that you can go online and look to see how your surgeon, your individual surgeon, in a case mix adjusted way, is performing. The surgeons get a lot more detailed information like this, and surgeons are so competitive. My God, do they want to not be average? You would not believe that they can't accept that 50% have to be below average. And it's quite interesting when you look at it and look at the quality of life improvement that you can achieve. Here to the right is patients who record an improvement, and to the left, those patients who have no improvement or worsening of their quality of life. You can see for groin hernia surgery and varicose vein surgery, 6 months down the line, really no great benefit for patients. Doesn't mean there's no value to the procedure, but patients aren't reporting the same thing. But hip replacement and knee replacement quite clearly change people's lives. And I'm not saying that because I'm an orthopedic surgeon, because I don't do any elective surgery. I only do trauma surgery. When we look at the condition-specific scores, usually designed by the clinicians, we see a different shift. We see far more improvement being recorded. And that is perhaps what you'd expect, is that relating to the individual joint or the individual site, there is a greater shift. It also, and this will be very true, I'm sure, for your country, it starts to get underneath the skin of the variation we have in the population before they undergo treatment, and the inequality and rurality issues and deprivation, which are big issues you can see in England. And so just because you get one level of change, you've got to understand the baseline for that surgeon or that hospital's performance. So what I hope I have in some way done today is to suggest to you that, as was quoted here, that's what management is all about. It's changing those thousands of decisions at the clinician-patient interface in the direction of better quality care and providing services at reduced costs. I would argue you can't do that with top-down hospital episode data. You've got to do it with clinicians, and there's got to be an equal responsibility on the clinicians to do that. And you need to be aware of that, because if you don't endorse and encourage that, you'll be left wondering why the Ministry of Magic hasn't come to help you. So having done all of that, and I thought I was going to retire back to my academic unit in Oxford, I was, should we say, persuaded when NHS England was formed 2 years ago, or 3 years ago now, to take on a transformation of the whole of urgent care. This is everything, not just the small areas. This is networks from major hospitals through to the smaller hospitals, through the whole of access to general practice, urgent helplines, ambulance services, community pharmacy, self-help. And this is where, and I'm not in any way being negative about activity-based funding, because we couldn't have done what we've done without it, but we started to recognise some issues. We had a system, because we had activity-based funding, that the providers were competing for the activity, which wasn't necessarily the flow that we were trying to engender. When we describe the network that we see there on that slide, what we're talking about is not networks like we have for cancer, for major trauma, where you're trying to draw patients in with over-triage into a specialist centre, but rather networks where the flow was in the reverse direction, that the major centres were supporting the smaller hospitals where that specialty wasn't. The clinicians in the smaller hospitals were 24/7 available to support decisions in the community by general practitioners, paramedics, community nurses, so that nowhere in the system will a consultation be occurring in isolation, such that, but for a bit more expertise, seniority or wisdom, I could treat the patient here rather than sending them to the next level of acuity and probably into hospital, where there is higher cost and less good outcomes and far less convenient for patients. So that's what we were trying to do, but we had hospitals that were fixed on activity. We had some coding creep that had gone on as well, which you'll recognise. I call it coding creep. It's probably much better coding initially than there might be a bit of gaming. You also had some issues about handoffs of complex cases because they weren't seen to be profitable. And you could get a distortion in the system if the activity-based funding was inconsistent. And the problem I had when I went out to describe that model of the network care that we wanted to move to was that when I looked, people came back and said, yeah, we totally agree, that's what we want to do. We do not want dormitories full of old people in ever-enlarging hospitals. We want to be treating people out in the community at the place that's most convenient to them and supported in a way that's most effective, only drawing those people into a level of acuity or specialism that their illness or injury demands. But one of the first things people said to me, they turned around and said, if you don't change the payment system, we can't do this. And the reason being is that our general practitioners are funded on a capitation-based payment. Our community pharmacies have a capped activity contract. Our emergency helpline and our ambulance services, there's a national currency that we set, but it's a local pricing. And that's significantly varied. Our emergency departments are an activity-based DRG contract, but our unscheduled emergency admissions are an activity tariff, but with a marginal. Our community services are on block contracts, and so are our social services. So if we've got everybody together in the same room as we do to agree that this is the way we want to go, and this is the direction of flow our patients want to move in, and even if they love each other so much, all these people, that they want to put all their money in the middle in a shared pot, when it comes to do the allocations, we're stuck with the fact that the hospitals can't afford to give up activity because everything's dependent on activity. The GPs, pretty nonplussed really, they're going to get paid on a capitation-based payment anyway. And social care and community care can't react when we need them to because they made their allocations at the start of the year and they've got no flexibility. So there was a strong call, but we didn't want to lose the activity-based funding elements. So an orthopaedic surgeon suggested we should change the whole payment system of the NHS to monitor and finance directors in NHS England. That was an interesting meeting. Because what I basically said was if the payment model doesn't tell the clinical story, on the evidence we have to date, it almost certainly won't work. So if we want to drive the flows across the system between providers in the way we want to, we know it won't work. And when we've done the analysis now, if we look at an acute service in a hospital like general medicine, somewhere around 75 to 85% of its costs are essentially fixed in year, irrespective of activity. If we look at the ambulance service, over 90% of its costs are fixed in year, even if the phone never rang. You've got to have those vehicles, you've got to have those trained crews, you've got to have that dispatch centre. If you go to an urgent care centre, ambulatory care unit, something like 50-55% of costs are fixed. So what's the point in making all of that activity-based? Because if you make all of it activity-based, you're going to have a problem in making changes. So we're going to start shadowing a new model from next year. And this may not work, but this is what is the thought process. Is that essentially in your network, if you are designated to be a service and you've got to be on call, always available, then there should be a core payment to recognise that. And that helps the smaller rural hospitals that just don't have the same activity. Yes, there is a volume component, an activity-based funding component, but that's probably categorical rather than incremental, because if you put a tier of nursing in or you put another CT scanner in, you don't get an incremental rise, you get a categorical rise in the amount of activity that can absorb. And then we have, based on our experience, a chunk of the payment model which is based around quality. And that will be based around core standards in terms of facilities, around process measures where we're doing a development in the service to drive it, and around incentives and sanctions. And I've talked about that already. But my view is we probably should only use sanctions and penalties to protect patient experience and patient safety whilst we go through a transition, so nobody takes their eye off that ball. It'll be an open book model, so all the providers will know in essence what everybody's getting, what the activity shift is planned, and what it will look like. And you will probably incentivize those providers who have to lose activity because they will not get increased activity income, but they need to change their business model over the next 3 or 5 years to adapt to the fact their services are going to be different in the future. We've got to create a model of funding that allows us to move forward. We're likely to end up with something that looks like alliance models for commissioning and contracting and something like perhaps ultimately the prime provider model. And this will allow us to get in steps towards that. It's quite difficult to jump from where we are now to a total population budget type funding model because people don't know how to get there. And it's really difficult to work out the risks to get us there financially. So this is a way of walking us there in steps that people understand the size of and have a measure of. And that's partly why we want to shadow it next year with every provider, so they start to think about what it might mean. So we need to move to a healthcare system away from what we have now, which are summative assessments, which score at a point in time around performance or fiscal targets, to something that's far more clinically credible, and the assessments and the performance actually engenders improvement. It's a formative assessment and not a summative assessment. Education's known about this for decades. And it's got to be across the whole pathway of care. It can't just be one provider, the hospital or primary care. So in closing, don't forget the clinician in your design. It's like a Formula One team. It's not about just measuring the lap times. Every single element of the pit stop, of the fuel design, of everything, the tyre wear, everything has to improve by a fraction of a percentage to get to be the best. In the health service, though, all the cars have got to pass the finish line at the same time. But that aside, that's what we've got to do. And the clinicians bring a level of knowledge and expertise which only they have, and particularly around clinical risk, which is the one place you can't go. They can go there and say, yes, the system can live with this risk and can manage it. So what is leadership? Well, it's a capacity to turn vision into reality. And I would hope I've convinced you that the first lesson is that clinical teams can be trusted to design and commission best practice and best value services and select the measures by which they should be judged. Secondly, deriving policy through multi-professional and patient consensus has enormous credibility and ensures engagement and ownership when you come to land it in the system. Linking payment for performance and public reporting are key in ensuring progress and sustainability, and particularly easy to let the politicians stand back and not interfere because the system is changing itself. But don't forget, don't be naive. Those pounds, those dollars are spent at the patient-clinical interface. That's what we've done in England. I hope some of that is relevant for you. And if I've got one message for you in this room, it's don't sit back and wait for it to happen. Thank you very much.